Thank you so much. This was really a very educational lecture. So thank you, Dr. Tanga. I will probably focus on some aspects that you already talked about. And of course, we will focus on this retrograde session on how to track vessels and how to do the reverse cart and something else. So as you mentioned before, we start our procedure based on the anatomy. So it is the anatomy that dictates the strategy we want to do. And this is the global algorithm. I don't want to go deep into this algorithm, but just to tell you that the point 5 tells about a feasible retrograde option. So what does feasible mean? Of course, it depends on the expertise of the operator, because feasible retrograde option means you have an interventional collateral. But what is an interventional collateral? It is different from operator, and also for the same operator in different levels of his experience. So this is what Manos Prilakis showed very well, that there are different steps in learning CTOs. And of course, the last two steps are those that go through the retrograde connections. And the most difficult is going retrograde to an epicardial from an ipsilateral epicardial. So we have also grades of complexity into the retrograde field. And if we analyze the type of collateral that we can use as an interventional collateral, we may have three types of collaterals. Of course, we talked about the septal, and we will focus on the septals. But we also have the epicardial collaterals, and sometimes we have bypass grafts that can be used. So everyone, I think that we share the same opinion that we do not want to go through a patent Lima artery to the LAD. So we do not use this as a connection collateral, but we can go through venous bypass grafts. Actually, the first retrograde CTO was described in the 90s, was through a retrograde saphenous vein graft to the LAD. And we can use bypass grafts that are open or occluded. It's not a problem. Of course, there are differences, but the most important thing is that the perforation risk, actually the tamponade risk, which goes with the perforation, is very high for the epicardial. So that's why they are very dangerous, and we have always to be very careful when managing epicardial. While this is not so true for the septal, that may be difficult to cross, but they are pretty safe. So I will go through these steps, which are the steps that I usually use in my mind to cross an epicardial and to cross a septal, sorry. And the first one is to understand which one I want to cross. So Dr. Tang already explained that it's very important to review the basal angiogram a lot. You have to spend a lot of time on the basal angiogram. And you also have to know which are the projections that you need to have to evaluate thoroughly a septal collateral. So basal angiogram, if you already see there are some collaterals to the right system, that means the right is occluded, you spend a lot of time to try to find usually the RAO projections, RAO cranial and RAO caudal, in order to see the collaterals and to see all these collaterals. So the RAO cranial is very helpful to see the origin, so the takeoff of the collaterals from the LAD to the right. While the RAO caudal is much more helpful in order to see the tortuosity, especially close to the posterior septum, which is the part where the collateral is most tortuous. And also, if you have an occlusion of the LAD, usually the RAO projection is very useful in order to identify the good collateral, the good septal collateral. So the first step after selecting our collateral is to go with a routine guide wire. So sometimes I use the same guide wire, but a good rule is to take the guide wire you are most comfortable with. And in this case, this is a routine. So it's an NRHC guide wire with a microcatheter. You bend the tip of this guide wire in order to get into the septal, and you get into the septal. Once you get into the septal, as you can see on the right-hand screen, you advance your microcatheter. And this is the situation where you can, if you want, do a tip injection, as Dr. Tang already explained very well. We have two possibilities. One is to do a tip injection to put our image on the reference screen, and then to try to follow the path of the vessel with our guide wire. And the other technique is to surf, so just to rely on the basal angiogram done with the retrograde guiding, and try to advance a guide wire in the septum. So this is the tip injection. of course, there is a risk of dissection. One tip is also to have a good backflow on the syringe. So one of the most difficult things to find in a cath lab is the good Luer lock syringe, 2.5 syringe to do the tip injection, because it must be very robust. But you also always have to try to have a good backflow in order to avoid possible complications. Then you do this tip injection, you put your reference image on your left or right hand as you are used to do, and then you go with the guide wire, and this is the real-time crossing of a guide wire through this septal. So this another situation is the surfing. This is a single, let's say, almost a single. There are two collaterals from the left, in this case from the right to the left system. And in this case, you see that there is no tip injection. We just advanced the guide wire based on the basal angiogram, and the wires goes through. So these are the two techniques, surfing or contrast guided to cross the septal. Another very important thing that Dr. Tang already mentioned is that usually we do not perform a lot of injection, contrast injection during retrograde PCI, but this is the most important one in my mind, because you have to be aware of the position of your retrograde guide wire when you go through the septals. Because if you advance a guide wire outside the vessel, it's usually not a big problem. But if you advance a microcatheter outside the vessel, you create a very big perforation, and this may lead to cardiac tamponade, or in the septal is more rare, but you can also have problems also in the septal. So just be aware of the position of the guide wire. On the left hand, you can see that the guide wire is somewhere probably in the right ventricle, and we just readdressed the guide wire, and this is the correct position of the guide wire in the PDA. Once you are sure that your guide wire is in the good position, you have to advance your microcatheter. And this is what you have to do. You have to push with your left hand and to spin with your right hand. And you also need to know which are the characteristics of your microcatheter. There are braided microcatheter, they cannot be spinned, so they have only to be pushed, the carotel, the fine cross, etc. Or there are microcatheter that need to be spinned, like the Along 2.6, the Corsair, the Turnpike family. And the ones that come from Asia, is what I learned, are turned counterclockwise, and the ones that comes from the US, they are turned clockwise. So the TLFS clockwise, and the Corsair and the Long, etc., counterclockwise. So anyway, you need to know the characteristic of your microcatheter, and usually a torqueable microcatheter is more pushable than a non-torqueable microcatheter, and so it's the preferred microcatheter in this situation. So again, a case example. This is a crossing of the septal with the any reach C, so at 0.3, so very soft tip guide wire through the septal that goes to the PDA. And again, we could advance the microcatheter after that. We also have epicardial collateral. So I want to focus, we were supposed to focus on the septals, but just to show that also the epicardial collaterals can be crossed easily, but you have to select them very carefully. And again, you use your microcatheter, you use your routine guide wire in order to select your epicardial collateral. And then what you have to do is the same thing. You just enter and do a tip injection through the microcatheter in order to well establish the course of your collateral, which is very, very important, especially in the epicardial, because you cannot serve the epicardial, you just have to do the contrast guided technique. And then you can advance the guide wire, and this is any reach C03 that goes through this epicardial quite easily. You can see that, as Dr. Tang said, we just need to spin a little bit our guide wire without pushing, and usually in diastole it goes further and gets to the distal target vessel. So this is a case that I want to show you. It's a brief case, so it would be 1 minute video. You see there are connections, the right is occluded, there are good septal connections from the left system to the right system. This is the projection that we use. You see that in this case we just injected through the left. And this is the antegrade knuckle, which is the safest way in order to establish the vessel course. This was an ambiguous proximal cap with an ambiguous vessel course, and so we knuckled down a polymeric guide wire in order to get access to the distal vessel, even if we are in an extra plaque, intentionally in an extra plaque situation. Then we do our retrograde injection in order to see the position of our antegrade system. And this is the combination of the Corsair Pro XS, so a torqueable microcatheter, and the NRH 06 in order to get into the septal. Again, we did the tip injection in a right caudal projection, and after this, we decided to go through the septal with an NRH P03, which is a polymeric coated guide wire with a coiled tip, so a very safe guide wire that goes very easily through the septal branch. And so, after getting to the distal right, we advanced and retrograde NRH P. This was a 3 gram, actually, not a 6 gram, in order to do the reverse cut. And you can see that we are advancing an antegrade guiding catheter extension on a balloon on the middle CA in order to externalize the retrograde guide wire. Then we advanced another guide wire on a Sasuke, so on a dual lumen microcatheter to get to the PD, to the posterolateral branch, and this is the final result after having stented up the body of the occlusion and the right coronary artery, and both branches are open, so combination of antegrade and retrograde, and this is actually a good final result of this procedure. So what we did here is a reverse cut, and Dr. Tang already mentioned it, so I don't want to lose a lot of time on this. This is one of the 4 techniques we use to recanalize CTOs. So it is the retrograde dissection and re-entry technique, and this is the most common technique when you go retrograde. So we need to have an antegrade balloon, and we need to have a retrograde guide wire to create a space and to advance our retrograde guide wire into the space that we created with the balloon. What is the situation? What are the situations that we can face? 4 situations, actually. This is the scheme of the position of the 2 guide wires. In red, you have the antegrade, and in green, you have the retrograde. Both guide wires, like in panel A, can be in the intraplaque space, which is a very favorable situation. In this case, probably you do not need a 1-to-1 ratio balloon. You just need a small balloon to create a space between the 2 guide wires and to connect the 2 guide wires. Situation B, both guide wires are in the same space. In this case, it is the extraplaque space. Again, favorable situations. In this case, we need a bigger balloon in order to put the guide wires together, but they are already in the same space, which is an extraplaque space. Situation number C is when you have your antegrade guide wire inside the intraplaque and the retrograde is in the extraplaque. So this is not a very easy situation, but you can connect by using a big balloon. So in this case, you really need a 1-to-1 balloon because you have to break all the tissue layer till the retrograde guide wire, which is suboptimal. And the last situation is the most difficult. You have your retrograde guide wire in the intraplaque and your antegrade in the extraplaque. So as Dr. Tang already mentioned, if you dilate the balloon here, you will push all the true lumen somewhere, and if it is calcified, you may also break your adventitia. So you do not have to use big balloons here. You just need to readdress your retrograde guide wire in order to put your retrograde guide wire in the extraplaque and transform the situation D to the situation B. Okay, is it clear? This is very important in order to understand which type of balloon of guide wires you need to use to create the connection. And these are the same images. I don't want to spend time on this based on IVUS. So this is a case just to show you the IVUS run on the right, and you can see that both wires, the one in the IVUS and the retrograde, are in the same space, which is an intraplaque space. They are very close. So we do not need a very big balloon here. So we do not need a 4-0 balloon like the vessel to create a connection, because this is the situation number A. And so we dilated and we made the connection with this balloon. And this is a conventional, let's say, reverse cut. Okay? And this is the result. Again, another case is that another situation is that we can use a guide extension catheter in order to make a reverse cut easier. In this case, we need to advance a guiding catheter extension on the antegrade guide wire. So we use the balloon to advance it. So what may happen if you have if you do not succeed in doing the reverse card? The first thing to do is to take a bigger balloon or to take a stiffer wire. This is what Dr. Tang already said, and is perfect. Sometimes you do not succeed again, so you are in a failure mode, and the best thing to do is to do IVUS. If you do the IVUS in this situation, you can see that both wires are here in the same space. They are already connected. And then coming back with the IVUS, you see that the retrograde guide wire gets outside, like into the plug, and then out the plug. So this is an extra plug position. So it will be difficult to make a connection here while we already have a connection in the distal part where the two wires are very, very close and already in the same space. And so what to do in this case, just advance your guide extension catheter at the level where the two wires were in the same space and externalize your retrograde guide wire. It is only a matter of patience, but in few seconds or minutes, you will get your retrograde guide wire into the antegrade guide extension catheter, and that's the final result. And then I go to the end with the last example, which is again a CTO done through the septals. This is an LAD CTO with a lot of bifurcation branches here. There are diagonals, there are big septal branch, there is an ambiguous proximal cap. So this is not an easy case if you want to maintain all the side branch. And when you are dealing with the LAD, we want to maintain all the side branches. So again, retrograde with antegrade with an along 2.6 and reach P3, which is extra plug, retrograde with an elong 1.7 and an reach P03. You see the crossing of the septal, very easy. It was not a very complex septal, actually. It crossed it very easily. And then we were able to advance our microcatheter through the septal. So the microcatheter, you can see here, the marker goes through. And this is our retrograde, and you reach E. Again, this was not the 6 because it's not available yet in my cat lab, but it was a 3. Sorry for the mistake. You see there are a good overlap of the two guide wires. And again, if we want to preserve the septal branch, the diagonal branch, we have to get our retrograde guide wire beyond the bifurcation. So in this case, we advanced an antegrade guide extension catheter on a balloon beyond the bifurcation, and we externalized the retrograde guide wire. In this case, we needed a stiffer guide wire because we had to puncture the tissue plane, and this was done with the Gaia second guide wire, which was advanced into the retrograde. And this is when then we need a rendezvous, which is another technique. You can advance an antegrade guide wire, an antegrade routing guide wire in the retrograde micro, which is in the antegrade guide extension. So this transforms the retrograde PCI in an antegrade system, and then this is the final result. The distality is not that good, but it will grow. But you see there are all the side branch are there. So to conclude, I think that again, I just stress what Dr. Pang already said. We need to select the most appropriate collateral, which is depends on our experience. To engage the collateral with a guide wire, workhorse guide wire, and a microcatheter, do it injection if we can, and select the appropriate guide wire to cross it. Also, the microcatheter needs to be used in the good way. And again, cross with the guide wire, it's not done until you don't cross it also with the microcatheter. So keep quiet, keep calm, and go on very slowly in this situation. And then you have to master the reverse cut, and if you do not succeed with the standard reverse cut, use IVUS to help yourself. Thank you.